Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Good evening. Welcome to the Wild Health Update for Tuesday, April 7th. In the United States, as of Monday evening, the CDC reports 374,000 confirmed cases and 12,000 deaths in the United States. The case fatality rate is 3.22%. As of this afternoon, Worldometer reports 385,000 cases and 12,230 deaths in the United States and approximately 1.4 million cases worldwide and 78,000 deaths. Data from the Financial Times shows that new cases in the UK are beginning to plateau at around the same stage they did in Italy and Spain. The UK death rate is following a similar trajectory as Spain and Italy, where deaths peaked around 24 days after lockdown. This suggests that deaths in the UK could peak in 7 to 10 days. Daily new cases in the United States, however, continue to rise with more than 30,000 new cases a day. The United States has also averaged 1,000 deaths per day over the last week and continues on its steep trajectory. China reported its first day with no new coronavirus deaths since January. Right. The lockdown in Wuhan was officially lifted today. This morning, New York City reported 731 coronavirus deaths in the past day. Mike, just for clarification, did it come across that I don't believe the 0 new deaths in China?
I mean, I just barely grasped that. Yeah, it's just...
Okay, all right. So going to New York City, they reported 731 coronavirus deaths in the past day. It's the largest single-day increase in deaths since the beginning of the pandemic. Over the weekend, New York has seen a decline in deaths 2 days in a row, making it seem like the outbreak was leveling off. In his daily briefing this morning, Governor Cuomo pointed out that the death rate was a lagging indicator and that the declining rate of hospitalizations is a better indicator that the outbreak in New York may be slowing down. Researchers from the American Enterprise Institute released a report that outlined several benchmarks the country needs to reach before being able to safely reopen and resume public life. We are currently in phase 1, slowing the spread of the virus primarily through social distancing measures. Individual states can safely move on to phase 2, reopening the state and resuming public life, only when they have achieved the following criteria. Number 1, a sustained reduction in cases for at least 14 days. Hospitals in the state should be able to safely treat all patients requiring hospitalization without resorting to crisis standards of care. The state should be able to test all people with COVID-19 symptoms, and the state should be able to conduct active monitoring and isolation of confirmed cases and their contacts. Once the above criteria are met, states can slowly proceed by loosening social distancing measures and reopening schools and businesses. Finally, states can move on to phase 3, establishing protection, then lifting all restrictions once an FDA-approved vaccine or broadly effective therapy is available. I really like this report, Mike, because it lays out these clear criteria that need to be met, because I think what we're going to see is our states and other local municipalities wanting and just kind of itching to open up. And we may see people opening up too soon, but if we can agree on the criteria, then we have something objective to say when we can open up. And the situation is dynamic. It's going to change, but I think these are pretty good overall metrics.
Yeah, I think so too. I think you're likely to see some states open up and then have to close back up because they see a big spike in cases. I think that's likely. With
Well, and we've seen that in other countries as well.
yeah, and from the 1918 Spanish flu, the second spike was worse than the first. So we definitely run the risk of not managing the public health issues appropriately after this first phase 1, as they're describing it. Certainly a risk. So we'll have to be really cognizant of what we do next.
We're getting a lot of questions about the recordings from the summit over the weekend. So just as a reminder, we're going to be releasing all of those on the Wild Health podcast.
Got a few articles to talk about today, Matt. The first one, and the one I'm probably most excited to talk about, is this article that came out of Annals of Internal Medicine. It was released yesterday on April 6th. Effectiveness of surgical and cotton masks in blocking SARS-CoV-2, a controlled comparison in 4 patients. I don't think I've ever done a literature review on an article in 4 patients. So this is an article where basically they took 4 patients who had documented CoV-2 by respiratory viral PCR, and they took a petri dish and held it in front of their face at 20 centimeters and had the person cough into it 5 times. They coughed into it 5 times without a mask. Then they wore a surgical mask, like a standard surgical mask you would see in a hospital. They wore a cotton mask, and then they did it again without a mask. And 3 of the 4 patients had positive findings. So 1 patient didn't even have a positive finding with their initial regular cough. So pretty much ditched that patient. Then they measured the viral load with each one of those findings. So with the average viral load without a mask was 2.56. The average viral load with a surgical mask was 2.42, and then with the cotton mask was 1.85. So actually the lowest with the cotton mask. So a couple of thoughts on the study. First off, it's 4 patients. Actually, it's 3 patients because 1 person didn't even have good data that they could use. And then also 20 centimeters is 7 inches. So that is literally someone coughing in your face. I don't know about you, Matt, but I don't even stand that close to a patient when I'm listening to their lungs. Like 20 centimeters is crazy close. The proximity reduces the importance of large droplets as well. So, because you're so close, now we're talking about much easier transmission of aerosolization rather than actually measuring large droplets, which is what we typically talk about measuring whenever we're talking about surgical mask or cotton mask. So it makes aerosol that much more important. I'm not trying to say the data is not important and not useful to some degree, but there's 50 articles documenting the importance of mask wearing for viral transmission. So let's listen to those when it comes to deciding whether to wear masks or not, and use this one to argue that we should probably be wearing N95s if we're healthcare workers and within 7 inches of our patients.
Yeah, I mean, this tells me that I don't want to be in front of someone's face if they're coughing and they have COVID-19. It also tells me that this is a good time to be trying to publish papers related to SARS-CoV-2. So those are my 2 take-homes from that.
Certainly. Annals of Internal Medicine is actually a pretty challenging paper to get published in. I mean, it's crazy, some of the study, like the numbers and some of the studies that we were seeing published in some of these journals. I mean, previously, in order to get a study published in like New England Journal of Medicine or Science or Nature, if it's a clinical study, you've got to have the standard randomized controlled trial, double-blind, placebo-controlled, 2,000 patients. I mean, it's these just astronomical numbers that cost millions and millions of dollars. And I know why it's happening. I mean, we've got to translate the information and get it out there as quick as possible. So it makes total sense. But we've got to continue to read these studies with a scientific hat and not just take the title of the article or the basic discussion from the authors at face value. You've got to take all this stuff with a grain of salt.
I mean, I would say, though, one thing that I would say from this article is I was surprised with, it's a tiny study, obviously, but I was surprised with how little the mask helped in this very limited situation. So what I would say is we still should wear masks, but I think this is very clear evidence of why you don't have permission to just gather in large groups just because you're wearing masks. So again, going back to the social distancing, how useful masks are, I'm not 100% sure. I'm sure they're useful, and I think we need to wear them. This casts a little doubt on how protective they are, but it just highlights the fact that social distancing is the thing right now.
I think that's a good summary, and that's probably the best spin to take from it. I don't think we can necessarily say that masks are useless. That is definitely not the spin that you should take from this, and you're likely going to see that to some degree in some aspects of the media. So take it with a grain of salt. Another article I wanted to talk about comes from Lancet Rheumatology on April the 6th. This is a letter that was written to the journal called Preventing COVID-19 Induced Pneumonia with Anti-Cytokine Therapy. The disease severity and death rate associated with COVID-19 are the highest in the elderly and among people with comorbidities. Patients with immune-mediated disorders like cytokine blockers that are thought to be at risk because of these drugs inhibit molecules involved in the body's host defense of foreign pathogens. However, there have been no increase in pneumonia due to SARS-CoV-2 in these patients, posing the question of whether patients with immune-mediated disorders on cytokine inhibitors are resistant to COVID-19. This is interesting. This is basically saying that there might be some protective nature to being on these immune modulators if you've got an autoimmune disease. So what the author is suggesting is that you should not stop taking these medications because you're worried about it actually decreasing the function of your immune system, because at the same time it might also be decreasing the likelihood of getting cytokine storm and a progressive pneumonia. I think it's a pretty strong argument, and I think I would put it in the same camp that I put ACE inhibitors and ARBs, in that there might be some protective nature of these drugs in preventing progressive disease. So certainly, even if you have a slightly increased risk of getting mild disease, wouldn't you rather prevent the progression of disease? So recommending that people who are currently on these medications continue taking them. And I think that makes a ton of sense.
Yeah. And I don't think this is, I think this answers kind of an important question, and it's not an esoteric question. This is a question that people are having. People that are on these cytokine blockers or immune suppressing drugs, this is a question that everyone has right now. So I think the common wisdom was to stop taking them, but this is kind of telling us that may not be the right answer. So probably not do anything other than talk to your physician about it and maybe bring the study up with them as you're discussing it.
Another interesting article that came out of Clinical Immunology. This is being published in May 2020, just released online. Potential effect of blood purification therapy in reducing cytokine storm as a late complication of critically ill COVID-19. So this article is talking about managing cytokine storm and how there might be this beneficial, basically blood purification therapy. What is happening is you're using this blood purification therapy kind of like dialysis, but instead of removing all the things that we typically remove out with dialysis, you're actually removing out some of the interleukins and the cytokines, and theoretically these things that are causing the cytokine storm. So this is a case report. They talked about a few patients and these 3 critically ill patients that were treated with these methods. This was in Wuhan, China, in addition to ventilation, antiviral, steroids, all the other things that you typically get. They saw decreases in IL-6 and CRP and an increase in the white blood cell count, which occurred after the blood purification therapy in those patients, basically indicating a recovery from the cytokine storm, which is interesting and I guess makes sense. I don't know how easy it would be to implement this on a wide scale basis. That's obviously something that would be a little bit more challenging. Last article I want to talk about is imaging and clinical features of patients with the 2019 novel coronavirus SARS-CoV-2, a systematic review and meta-analysis. This is a good one to talk about because it just goes over some of the basics of the epidemiology of the disease with a fairly remarkable number of patients. So this one has 46,959 patients, which were reviewed over 31 separate articles. They found that 87% of people had fever, 58% of people had a cough, 38% of people had shortness of breath, 35% of people had muscle soreness or fatigue, 31% of people had chest distress. And in terms of the main imaging, they found bilateral pneumonias in 75% of patients, ground glass opacifications in 70% of patients. And in terms of the patients that required the ICU, they found 29% actually require an intensive care unit. And in the number of patients that got ARDS or acute respiratory distress syndrome, 28.8% of patients got that. Multiple organ dysfunction syndrome was found in 8.5% of patients, and the case fatality rate total was 6.8%. So obviously this doesn't include everyone who's had COVID. We're up to 1.4 million, but this does include 46,000 patients. So pretty large number, and some helpful information regarding the epidemiology.
Yeah, and I think there's not anything clear in here like, hey, take this medication or do this or do that. But these descriptions are important because there's a lot of questions right now. You and I were discussing just earlier, kind of an editorial talking about, hey, this is different than other things we've seen. And a lot of people kind of proposing different mechanisms for what's going on with this viral infection because it tends to be, it's just behaving differently than things we've seen before. So these descriptions are important as we move more and more towards figuring out exactly what to do and coming up with good protocols for how to treat COVID-19. Tomorrow, we'll have Dr. Andrew Weil on the podcast tomorrow morning. Tune in for that. It was a delight talking to Dr. Weil at the summit. So tune in to hear his answer to me asking him to tell us a joke.
Thanks, everybody. Stay safe. Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at WildHealthMD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.